All right, let's see if that does it this time. So I'm back again, waiting to see if folks are able to chime in. See if we get the chat working this time. So if you haven't been to rejoin, I appreciate you and your patience. We try to get this thing working. There we go. Thank you. Got everybody in. See the numbers are growing up. Seeing everybody here. Hey, Blair, Sharon from Tampa. All right, I'm doing fine. Mike L, good to see you. Jax, what's going on? Becky, hello, Becky D. Ali, you too. Looks like Dana. Canada's in the house. Rich, good to see you, brother. Vincent. All right, appreciate you guys coming back. Again, Dr. Jefferson here, DC Foot Doctor, coming back to you with a back-to-back chat. Part one was yesterday, and we're here with part two. Hopefully, we'll be able to have part three tomorrow morning. Good to see people popping in. As you may have noticed, I've been a little YouTube dark the past couple of weeks. My family and I just got back from vacation in Costa Rica. We had a great time. If you're a traveler, like my family loves to travel, I suggest you put Costa Rica on your list if you have not already done so. It's a great country, great people, great service, great resort, a lot of great things to do, great experience, and seeing how things are done in other parts of the world. So we had a great time, and that is definitely on our list to return. Uh, Also, another thing that's been on my plate, a couple of months ago, I opened a second location in Prince George's County, Maryland, right outside DC. So not only am I the DC foot doctor, but I'm also the PG foot doctor. That won't be official, but it's cool to say. But the folks out here in Prince George's County, Maryland, have been very supportive, and that part of the practice is starting to blossom. So feeling very blessed and grateful for that. Uh, Also, I talked about yesterday the issues that myself and a lot of creators been having recently with YouTube/Google and monetization of videos. As you may have noticed, uh, a lot of videos, well, all of my videos recently, and a lot of videos from other creators in my genre have seen zero to little ads on their videos. So it cuts into our an added revenue stream for us, and it's something that we're trying to work out with YouTube. But I'm not leaving YouTube. YouTube has been great. You guys have been great, so we want to continue spreading the good word and the gospel of good foot health and health in general, and building this community with you guys. This would not be possible without your help. I want to thank you all for any super chats you may donate during this live, and appreciate that. It helps me with what we're doing in the practice, particularly with our underserved and underinsured patients. We've been able to give socks and shoes and other treatment things that are usually aren't available to them if they don't have insurance or they're underinsured. I mean, I've even had subscribers and viewers send me items to the office to give to the underserved population here in DC. So I want to appreciate that, and thank you for that. Another way to make donations to the channel is through Cash App. If you have that app available to you, all the information for donations in the description of this video. And thank you very much, Terry Jones, for your super chat. It's very much appreciated. The Cash App again is $ Dr. Kevin Jefferson. Thank you very much for that. Also, another way for me to better connect with my viewers, my subscribers, is through a web application you may be familiar with called Wisio, WISIO. Through this platform, you're able to submit questions, comments directly to me, either through text or via video. explaining what your situation is or what your comment is on a particular video, or if you have a foot or lower leg issue that you need clarification on or some guidance on, you can send me that video. Then I send back to you a private personalized video giving you my take, my expertise on your situation, so you will have better information to make a sound decision on your foot health and in general foot questions. Or if you just want to shoot the gip, as we say, that's fine too. We can talk about anything you like related to what we do here. I see we got Jacksonville. Who else is here? We got Nurse Marilyn. Good to see you, Marilyn Edmonds. Somebody just asked a question. I'm in Washington, D.C., and recently now I'm also in Maryland in the United States. Jacksonville again. ATL's in the house. Hopefully ATL was supposed to be back there for the National Medical Association annual conference. We were supposed to be there last year, but the pandemic and everything. And so it looks like we will be returning to Atlanta in full force in summer of 22. So we're looking forward to being down there. Donna Douglas in VA, my neighbor on the other side of the Potomac. Good to see you. Evansville, Indiana. What else we got? Waldorf down the street. You got to come see me, Rita. You're not that far. I'm in PG now, so you don't have to worry about parking in the district. So come on out and have a good time. Columbus. Kaiser is kind of weird. You have to go to the Kaiser Center for your health care, and it's kind of difficult getting outside contracts with Kaiser, so we're not taking Kaiser at this time. My friends, Williamsburg, one of my favorite vacation stops, going down through Williamsburg, Dory. So hopefully get down there, get back to Busch Gardens, and have a good time. Georgia, again, more Georgia folks here. Michelle from Georgia. North Carolina, Boston. All right, good to see you. Now, we're going to go forward a little bit. We're going to focus primarily today on the foot issue of onychomycosis or toenail fungus. So any questions you have regarding foot care, I will, at this time, give deference to those who ask about that particular issue. If we have other foot care issues and I have time to get to them, I would do that. Now, if I miss your question or miss your comment, there's a lot coming through. So please repeat your question for you. Again, my wife, who usually moderates my lives, is not here on this evening. So I'm kind of flying solo. So if I don't get to it during this live stream, I'll be able to answer any questions in the replay, in the comment section of the replay. Thank you very much. Again, more Ohio, some more Virginia, Providence, Rhode Island. Very good. All right. So now, Ginger Spice 414. How far up to the leg do you work? Pain in right toe. Here in DC, the scope of practice in any medical profession is what your license allows you to do. So in DC, we are allowed to go, of course, from the toe up to the knee. We can do any type of procedure on the foot and ankle. Above the ankle, between the ankle and the knee, we can do soft tissue procedures. So if you're having wounds or Achilles tendonitis or Achilles injuries, problems with your calf, things like that, podiatrists in Washington, D.C. are allowed to deal with that. It may vary from state to state. The profession is working on a national scope of practice, so it doesn't vary depending on where you live. So hopefully those things will continue to progress. Now, dealing with particularly onychomycosis, toenail fungus, is something that is essentially the bread and butter of any podiatric practice. Yes, we see a wide variety of foot issues, but toenail fungus is one of the things that we deal with very commonly, probably most commonly. I deal with it every day. There is no profile of a person who can come down with toenail fungus. I've seen it in all walks of life, all stripes, all ethnicities, all races, all male, female, young, old. It doesn't matter. We typically don't see it in children. Usually I start to see toenail fungus in late teens, early 20s, all the way up to folks in their hundreds. So it is something that we deal with regularly. We're very versed in it. And I must tell you right off the bat that contrary to popular belief, toenail fungus is curable. I had a patient who came in today with a fungal infection, and I recorded her for the channel, so you'll see her video in the days to come. And she was told by another doctor that her toenail fungal problem could not be cured. And I'm here to tell everybody here and everybody within earshot that is not the case. We have a number of ways to deal with fungal infections of the toenails, as well as fungal infections of the skin. So if you're having this issue, please go see a podiatrist. If you need to get a referral from your primary doctor in order to do so, do that, but you don't have to live with it. I've had patients who lived with it for 20, 30 and more years until they came to me and we went through our protocol and were able to get it cured. Now, as I was saying earlier, anybody's susceptible to it. Nobody's immune. So here are the things that we see that cause it. Now, a lot of people think that toenail fungus occurs because of poor hygiene, and that's not the case. Of course, if your hygiene is not very good, you might be more susceptible to developing fungal issues, but that's not always the case. I've seen patients that are professionals, doctors, lawyers, teachers, you name it, who have terrible fungal toenail issues. And I've treated homeless patients who don't have fungal issues at all. So walk of life is not always a determining factor, but there are some issues that make people more susceptible. Of course, we see fungal toenails a lot in diabetics. We see fungal issues in folks that have immune deficiencies, and that includes patients that are on chemotherapy or radio therapy for radiation therapy or for cancers, because these treatments and other medications, patients that are on medications for transplant to prevent transplant issues, patients that are on long-term steroids for different issues, whether it be rheumatoid arthritis, and things of that nature. All these medications, all these treatments lower their immune response. So they are more susceptible to developing fungal infections. But again, anybody from any walk of life can get it. What we see often also is that folks who are more exposed to moisture, whether it be from themselves, whether they have sweaty feet, or they work in situations where moisture is an issue. We see it a lot in folks who work outdoors, mail carriers, construction workers, folks who work in certain warm conditions, people who work in kitchens and whatnot. Of course, people do car washes, swimming and things of that nature. They're more prone to moisture, so their feet get wet throughout the work day. And often they have to wear a certain type of shoe or certain pair of shoes for their occupation. So they are constantly reinfecting themselves by putting the same shoes back on day in and day out. So that is a primary way of getting a fungal infection. But fungus is available, or not available, but fungus occurs in any setting, any home. If you leave a piece of bread out on the counter for too long, or an orange out on the counter for too long, it's going to get moldy in any house. I don't care how well you clean your counters and clean your tables. If those items aren't stored properly, they will mold. Mold, yeast, and fungi are all closely related. So you can get these organisms in the nails as well. It's not just what we call dermatophytes. Dermatophytes, what we see most often in the toenails, causing this issue. Dermatophytes are those fungal organisms that have an affinity for nails and skin. They typically cause toenail fungus infection and athlete's foot, which is also a fungal infection, but occurs in the skin, chiefly the bottom of the feet and between the toes. So any home is susceptible to it. When I was in the Army, when those government issue combat boots so many years ago, I developed a real bad case of athlete's foot. And fortunately, I was able to get some medication, some cream, and get it taken care of. It took a few weeks to get rid of it. But again, nobody's immune. It even happened to me before I went to podiatry school. So it can happen. Don't feel bad if you're dealing with it. There's nothing that you did wrong. You are not an unclean person. You're not nasty. It's just something that happens, but it needs to be dealt with. It is an infection. It's not a cosmetic issue. That's one of the issues that we dealt with in our profession years ago when we used to battle with insurance companies to have this treatment covered, is that insurance companies wanted to consider fungal infections of the nails as a cosmetic issue and wouldn't pay for it. So podiatrists years ago battled hard, and got it recognized as a true infection, the true infection that it is. And so now fungal nail treatment is covered by health insurance. So if you have health insurance and you have this issue, rest assured that you can get it treated and it be covered by your insurance company. Okay. Now, my protocol in dealing with this issue is such. Not all of us do it, but I find that it is most effective in figuring out what's going on and how to move forward. When a patient comes in with this issue, I get a good history, a background of what's been happening with this patient. How long have they had the problem? What did they first notice? Was it a thickening of the nail? Did it become crumbly? Was it a color change? How many nails were affected when you first noticed it? And has the problem worsened over the years, stayed steady, or is it getting a little better? Have you seen any other doctors or other health care professionals for the issue? Was it just your primary doctor? Did you go to another podiatrist or dermatologist who's been trying to help you with this? And if you have seen another professional, what type of treatment did you receive? Was it just cutting the nails? Was it that and medication of some sort? And if you had medication, was it by mouth? Was it topical, something you applied directly to the nails? Have you tried laser? What about, over-the-counter products? What have you bought from the local drugstore, or what have you purchased online to help you to deal with this issue? Let's get a good background story of what's happening. So one, I know where things stand. Two, we don't repeat something that hasn't worked in the past, because those type of things can frustrate a patient that they've tried 100 different things and none of them have worked. And so they've given up. And this is why they've had the problem for 20 years. But like I said, I have a protocol that's shown to be very, very effective. So after getting that the background story on it and figuring out where they are, where they've been, and where they need to go, what I do, you've seen it in the videos, is I trim the nails and I send those trimmings to the lab. I use a specialty lab in Alpharetta, Georgia. The name of that lab is Baco Pathology. They're very good. What I like about that particular lab is that it's actually run by podiatrists as well as dermatologists. Those doctors down there have been there, done that, seen it, wrote the book. So that's why I trust that lab, and they're very accurate and they're very timely. And so I would suggest that when you go to a doctor for this issue, you ask them to not only trim the nails, but send them for analysis. One, to see if it is indeed a fungal infection, and two, to identify the organism or organisms that is causing the problem. Every now and then we'll have a patient come in and there'll be multiple organisms that are causing the issue. Last week I had a patient that had a dermatophyte, a yeast, and bacteria in her toenails. So we need to know what to do for that patient and how to treat it and how to get her moving forward. Also, every now and then we'll have a patient come in with nail issues that look like toenail fungus. We trim the nails into the lab, it comes back, there's no fungus at all. It just happens to be what we call micro trauma, or the daily wear and tear of the toenails as we go through our day over the years wearing shoes. And the nails can take a banging sometimes, and they can get deformed, they can get crumbly, they can get discolored. But fortunately, because we do test the nails, we save the patient the frustration of using medications and spending a lot of money on stuff that wasn't going to work in the first place because it wasn't a fungal infection. So for those patients, there are other things that we recommend, like particularly urea compounds to help soften the nails. We teach the patients how to maintain their nails at home, not just trimming, but also filing and keeping the shoes disinfected, and wearing better fitting shoes and things like that to help decrease that wear and tear and soften the nails and make them easier to work with. Now, once we know exactly what we're dealing with, once we know what organisms that we're dealing with, now we know how to go forward as far as treatment. If all 10 toenails are involved and the nails are in real bad shape and they're very thick and very discolored and crumbly, there's no topical medication that's going to work. You can use all the available topicals, over the counter and prescription, and put it on the nails for years, and it's not going to make a hill of beans of difference, because those preparations will not penetrate a very thick, very what we call dystrophic, very hard, crumbly nail, and won't get down to where the true infection is. Most toenail infections take place underneath the nail, that is between the hard part of the nail plate, and the underlying skin, what we call the nail bed. If there's a significant infection underneath the nail, what we call a subungual infection, medication has to get there. So as a doctor, I have to be very judicious in choosing topical medications for those patients, because I got to make sure that one, the medication is going to be effective against a particular organism, and then two, we got to make sure that the nails are thin enough that there will be adequate penetration for the medication to be effective. Oral medication is also a good safe choice for a lot of patients, particularly in what I just described. Medications taken for a shorter period of time than a topical. Topical use is usually 6 months to a year of using medication. Oral medication, the actual taking of the medication is 3 months. After that 3-month period, there's enough medication still within the nail that it's working to clear the infection. Of course, another option is laser. Now, laser therapy is kind of hit or miss. Its effectiveness is lower than the other options, and laser is a safe alternative, but I have not seen it to be that effective from patients that have come and to my practice. So I have not seen, based on the research that I've done over the years, a particular laser that's very effective for it. But if there's anybody out there that's had effective laser therapy, if you know the name of the laser and the company, or if you're a physician out there, podiatrist out there, and you have a good laser company that you're very familiar with and that you trust, please send me that information. I'd love to hear about it. But again, I haven't seen it be too effective. I've had too many patients come to me who've had laser done somewhere else, and they spent $1,000, $2,000, and had no good results. Laser is what we call is FDA cleared Food and Drug Administration has cleared the treatment of laser for nail fungus. That means it's safe to be used on people, but that's about it. Now, there's another level, which is FDA approved. FDA approved is different from cleared. Cleared says you can go ahead and use it, doc. It's safe. You're not going to hurt anybody with it if you use it correctly. FDA approved means that this modality, this medication is approved for the use of getting rid of nail infection. Laser doesn't say that. The FDA did not say that about laser. So it's cleared. You can use it. It's safe. You're not going to hurt anybody if you use it correctly, but it's not approved to cure onychomycosis, toenail infection. So know that if you're going to try laser as a treatment, I don't discourage you from trying laser if you're not a good candidate for other therapies, whether it be oral or whether it be topical. Oral medications, any medication, of course, has its side effects. I've had a lot of patients who felt discouraged from taking the oral medication because they heard that it damages the liver. Now, the problem with that statement by patients, that they're kind of miseducated on the use of oral medications for toenail infection. Oral medications for toenail infection are cleared by the liver. You get it out of your system primarily by the liver, just like statins, medications that are used to lower cholesterol, just like alcoholic beverages. All these things are cleared by the liver. Other medications, other foods are cleared by the liver chiefly. If they're not cleared by the liver, they're cleared by the kidneys or both. So what we have to do in patients that are more susceptible, if they're taking other medications or if they have a history of liver issues, is either not offer them that therapy, or we do blood work, liver function tests to make sure their liver is functioning well and that they're a good candidate to use oral medications. But don't let oral medications scare you. I've never had to take anybody off of oral medication for nail fungus because of any liver issues. I've never seen anybody's liver function test elevate to where we had to stop it. So we do blood work often at the beginning, if need be. If we really need to monitor the patient, we'll do blood work again halfway, and then we'll do blood work again at the end if a patient really needs to be watched more closely than most folks. But I have no qualms giving people oral medication for it. It's been very successful. Topicals have been very successful, of course, in the right patient. So if a patient has a mild case of nail infection, maybe just a few nails are involved, the nails are not very thick, crumbly, maybe they're just a little discolored, maybe there's a little bit of flakiness, and we can use a topical on that patient pretty successfully if we know, or after we know, what the organisms are involved. So we do that with topicals. Of course, you have to use them longer because of the penetration issue. So again, topicals can go 9 months to a year. Again, orals you take for 3 months. Now, what everybody needs to understand, no matter what treatment modality is done, whether it be oral, topical, laser, combination, what we're really treating is not the nail that we see the day you come into the office. Those changes have already taken place. We can't take a hard keratin-based material like toenails and change that nail back to normal. Those changes are permanent in the nail we see today. What we're actually treating is a new nail that's coming in and is replacing the old nail we see today. In most healthy adults, it may take 4 to 6 months or so to completely replace or to grow new nails in all 10 toes. So for all 10 toenails to replace themselves, it's about 4 to 6 months, give or take. So that's why we wait about 6 months to determine how effective any treatment modality is. We don't consider anything a failure until at least 6 months of treatment. Some folks, it may be a little slow on the uptake as far as seeing improvement. And then some folks are pretty quick. I've seen, pretty bad cases of nail infection cleared in 3 months. And I've seen some take a year or more, depending on what the treatment is. So know that if you have this issue, it is treatable, it is curable, but there's also a part of the treatment program that's incumbent on the patient to participate. I always tell patients in these issues that we cannot rely solely on the medication. Just taking medication or putting medication on the nail or going into a doctor's office to get your nails zapped by laser is going to do the trick. There's no magic bullet for this issue. So aside from just taking medication, you also have to deal with your shoes. As I mentioned earlier in this conversation, a lot of people get frustrated because they don't realize they're dealing with reinfection of the nails, sometimes almost daily, because of their shoe issues. So I always recommend to my patients when we start them on a program for getting rid of nail fungus to, one, alternate your shoes. Do not wear the same shoes 2 days in a row. When you're done with those shoes for the day, you get an antifungal spray or something, or surface cleaner like Lysol or something similar to that. You spray out the inside of your shoes. If there are insoles in the shoes that are removable, take those insoles out, spray them on the top, spray them on the bottom, spray out the inside of the shoes. Leave the insoles outside of the shoes. And then you don't wear those shoes again for at least a couple of days. Give them a chance to give that spray a chance to kill all the organisms, and then give them a chance to dry out. Remember that fungus thrives in dark, moist, warm areas. So when we're wearing shoes and we're going throughout our work day, maybe our feet get a little sweaty, then, we're setting up the perfect environment for them. So alternate those shoes, spray them out, disinfect them. All these things need to be done to help get rid of this situation. Also, for folks who can, there's some physical labor you're going to have to do on your nails as well, particularly if you're using topical medications. You're going to want to file those nails down on a regular basis. I never recommend that patients, especially my diabetic patients and other patients with circulatory or nerve issues, to use anything sharp on their nails or on their feet. So nail file, pumice stone, something like that. File your nails down after they've been either in the shower or you soak your feet in a basin or a foot bath for about 10-15 minutes. You never want to work on your toenails or your feet while they're dry. You could cause irritation, breaks in the skin, and so forth. So do some physical labor on those nails as well to help cut down the fungal count, and that'll make things better. Now,